I'm Dr. Robert Elgin. I'm one of the partners at Michigan Institute of Urology. Thanks for joining us for this webinar tonight. Tonight we're going to be going through kidney stones, a lot of kind of basic information about what causes kidney stones, how to avoid it, procedural intervention, surgeries, things like that. We're going to walk through probably about maybe a 30-minute presentation or so, and then kind of the plan would be to go through these slides, and then at the end of it, we'll kind of open it up to questions. And then if you guys have any specific questions that I can help answer, I would be happy to do it. So this is a little bit of my bio. That's what I look like, or did look like. That picture is pretty old, but I went to undergrad at Miami of Ohio. I'm originally from Southern Missouri. I'm a Michigan transplant. Did medical school at PCOM, and then I did my surgical residency, urology residency here in Metro Detroit. I'm one of the partners at MIU. I go to a couple of offices, one in St. Clair Shores and one in Macomb County. My specialty in urology is really kidney stones, from diagnosis, management, prevention, surgery, like the whole thing. My kind of like passion is really like metabolic stone management and minimally invasive kidney stone surgery to remove larger kidney stones, and we're going to kind of go through some of those topics tonight, which is why you're here. So first of all, like starting with kind of a summary or kind of a high-level overview of where we're going, we're going to talk about what is a kidney stone, from what is a kidney stone to types of stones, prevention strategies, and then surgical options if needed. So before we talk about what a kidney stone is, we need to know like what is a kidney. So in general, a kidney is a paired organ. I mean, you have two of them in the body, filters blood, makes pee. So I tell my patients, like, the kidneys kind of like wash the blood. They take all the stuff you don't want out of the blood, and that's what's really formed into your urine. So whenever we get imbalances in the urinary tract, you get small crystals, little like particles that come together in the urine. Small particles stick to other small particles. These things crystallize, and then over time, generally on a very small or a very long timeline, these things kind of get bigger as life goes on, forming a stone and then causing drama that most of you are probably aware of. So kidney stones are incredibly variable. So that's one of like the interesting things about my job, is that these things they're all unique. These situations are all unique. Stone size, stone location, composition, it's all variable kind of all the time. And so, we have like a lot of variety in patient condition and how people present and kind of what they're going through and what they're feeling. So in general, kidney stones are kind of asymptomatic. You're not going to be aware of their presence unless they're causing an obstruction in the urinary tract. So I have patients that have kidney stones that are like literally like the size of your hand, like no joke, like the size of the palm of your hand. And they have no idea. They're like, I tell them, like, you got a problem. You have this huge stone, the kidney's not functional. They're like, well, I've never had pain. And that's pretty common. And so you can have stones that just sit in the kidney. The kidney is doing its kidney job. It's making pee. That urine is draining out of the kidney. And as long as there's not an acute, like, quick obstruction of that urinary flow, they're pretty comfortable and a lot of times asymptomatic. It's only whenever those stones fall into the drainage tube or the ureter, which drains the pee out of the kidney, causes obstruction, and then boom, 10 out of 10 pain, then you're in the ER. So it's mostly the obstructing stones are the ones that are going to be causing the big issues. As far as types of stones, this is a pretty generic overview. There's lots of stone composition out there. There's a lot of like really kind of like oddball stone types, but these are the most common ones. Calcium oxalate, you guys may be aware of that, but calcium oxalate stones are far and away the most common. With calcium oxalate stones, there's some imbalance. There's too much calcium, there's too much oxalate, there's some screw up in there. These things come together in the urine, stick together, small stones become big stones, and then you have a problem. Um, the kind of the second most common stone type would be uric acid. These are not as common. So probably about 10%, maybe 15% of the stones that we see would be uric acid. These can be formed by dietary causes. There's this slide says high purine intake. Well, what the heck is purine? Purine is like red meat and fish, essentially. So if you're taking in a lot of purine via a dietary source, then you can have uric acid stones. Most of the uric acid stones that we see are secondary to what we call metabolic syndrome, which is where it's uncontrolled diabetes, obesity. You have this kind of mix in the body of obesity, diabetes, like I said, that causes a change in the acid base concentration of your urine. And so as your urine becomes more acidic, then you can form these uric acid stones like really, really quickly. And so that's it. It's not just a dietary problem. I don't want to say that, but it's mostly like lifestyle and diet. Struvite stones, these are less common. I deal with a lot of these just because this is my specialty, but there's a certain kind of weird bacteria that is part of their lifestyle. They actually make stones. And so you get these bacteria that live in the urinary tract, and as they're reproducing and living their lives, like it makes this kind of like film, like sludge stuff that gets in the kidney, and that kind of crystallizes and comes together and forms these big stones. Cystine stones, super rare. Like I've got thousands of patients, literally thousands of patients that I see for kidney stones. I've got 3 people in my practice that are cystine stones. These people have been forming stones since they were like toddlers. This is going to be diagnosed very, very early on in life, and this is a real nightmare. But thankfully, super rare. So who gets kidney stones? So about 10% of the population will get 10% of Americans will get a stone during the course of their life. This is not super accurate for our part of the world. There's these weird parts of the world where you can have what we call stone belts. And so we know that there's a high density of people who make stones, like in kind of the southeast, for example. So like northern Georgia, Tennessee, kind of sweeping down through, Alabama, Mississippi, Louisiana, like that stretch of the country. There's a higher incidence of stone production there than say like Colorado. And kind of like in zooming in on Michigan, it's interesting because there's a huge population of people who have stones that are in kind of the northern suburbs of Detroit, and that's actually we call it like a Macomb stone belt. So from Flint across to the lake, that whole kind of stretch right there, there's huge population of people who have stones that's way higher than the rest of the country. So if you live in Macomb, then you're in that belt. So who else forms stones? People who don't drink enough fluid, eating the wrong foods. As far as food, we're going to talk about this a little bit more in depth here in a minute. But there's typically like high salt foods, high vitamin C foods. Those are like the big kind of dietary drivers. Intestinal surgery, abdominal surgery, gastric bypass surgery is like a huge one. You get all these like weird oxalate disturbances and acid base stuff, and it just can be like a real nightmare. And then, like I said earlier, with the diabetes and the obesity and this, what we call like metabolic syndrome, causing the acid base abnormalities of the urine, which go on to cause stones. Symptoms of a kidney stone, you guys know, most of you in the audience know. So flank pain, so pain in the back that radiates to the groin, that's associated with nausea, is the classic one. Blood in the urine, frequency, urgency of urination, etc. Kind of like what I said earlier. So very, very small stones can cause no symptoms because those are typically smaller stones are going to pass without causing a blockage. If you have a 1 millimeter stone, 99% of the population is that's going to pass, and you're not going to have any idea. It's just going to fall out of you, and then like, okay, well, I didn't even know that I had this issue. But larger stones causing obstructions obviously are going to be painful. Okay, so prevention. So what do we do? Like how do we prevent this from happening? And we'll walk through some kind of like dietary modifications here to help with that. The biggest thing, like overall, the biggest thing, far and away, fluid. It's like this is. I'm just remembering like something my dad's a civil and environmental engineer, and he always say like the solution to pollution is dilution, which I was as a kid, you hear that like 1,000 times, like shut up. But like in my line of work, like that's actually true. Like if you drink a ton of water, you're gonna flush out and dilute all of that minerality, all those crystals. You're just gonna wash them out of you. And our goal is about if you're making 2.5 liters of urine a day, that's great. Like you're gonna avoid a lot of problems. So like I tell my patients in general, as far as fluid, I want you at about 100 ounces a day, and I want 70% of that ish to be water, and then 30% of that can be coffee or juice or whatever. But fluids far away. That's the thing. That's the big thing. Other food choices. This thing called oxalate, which some of you guys may be aware of. The problem with like oxalate avoidance is that oxalate in general comes in like the good stuff, the healthy stuff, the heart healthy stuff, the low fat stuff. That's a lot of that is oxalate, like spinach, berries, nuts, beets, tea, rhubarb. Like those are all oxalate dense foods, but they can cause a problem. Other dietary choices is actually it may be counterintuitive, but we want you to take in calcium with your food. We want you to have 3 servings of calcium a day. Um, we know from studies that people who have a low calcium diet, they have a much higher incidence of stone disease. And so, whenever I see patients and we do testing in the office and their urinary calcium levels are like 0, I'm like, dude, like you got to eat some dairy. And people kind of look at me perplexed and say, like, what are you talking about? But having 3 servings of dairy a day is incredibly important. So, and then calcium supplementation is kind of like plus minus on that. If in general, if you're taking your calcium supplements with food, it's really not that big of a deal. If older women who have osteoporosis, osteopenia, who are needing to take like large quantities of calcium and vitamin D, we want you to take that with food. If you're taking that just solo, like on its own, that's a huge amount of filtered calcium load on the kidney, and we want to avoid that. As far as protein goes, like I said earlier, if you're someone who's a uric acid stone former and you're sitting around and you eat steak, 7 nights a week, like that's a problem. Like you need to make a change. And so that's something to avoid. And then high salt. So, and this is probably, I'd say behind chronic dehydration, this would be probably the second most common driver of stones that I see. And it's high salt, and there's a mechanism in the kidney where if you take in a bunch of salt, your kidney kind of freaks out, doesn't know what to do with it, and then you concentrate a bunch of calcium in your urine. That's a very like elementary way of describing it, but that's essentially what happens. Salt goes into your mouth, calcium goes into your urine, you form stones. So avoid that. And then high dose of vitamin C. If you're taking in a lot of vitamin C is just oxalate in the kidney. That's all it is. And so if you're having huge amounts of daily vitamin C supplementation, then that's going to be a problem for you. These are these like little bullet points about like protein and salt and oxalate and calcium and all that stuff. Like these are like basic generalities, but there's these stone conditions can form under like a huge spectrum of conditions. So, I've got people that have calcium based stones and they don't have their calcium levels in their urine are appropriate. They've got, their oxalate levels are good. They've got some other filtration problem, or they've got like a citrate deficiency. But the point I'm trying to get at is that these are like good, like kind of like general guidelines, but to get really specific on what the like specific etiology or cause of the stone is, we got to do testing. And so the testing that we do is we draw a bunch of blood, and then we collect your urine for 48 hours. So we have these very scientific devices called like a urine collection device, which is just like a bucket that you pee in for 2 days. And then I look at that, analyze it, see what's going on in your urine. And then essentially I can say like, okay, you have calcium stones, but your problem isn't salt, and your problem isn't like oral calcium. Your problem is blah, 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 blah. And then we kind of go down that rabbit hole. So, um, so now we'll move on to some treatment options. The majority of stones that people make pass on their own. They just go away. They fly out of you. So like the good, the kind of the good bullet point is 6 millimeter stone. It's got about a 50-50 shot of passing in 3 weeks. So if you have a 6 millimeter stone and it's in the urinary tract, it's in the ureter and it's on its way down, then it's a coin toss if that's going to happen or not. 80% of people who have a 4 millimeter stone or smaller will pass on their own within 3 weeks. I've got patients that can pass like giant stones. Like, people come in and they pass like a centimeter stone like once a year. That's incredibly abnormal. Like, good for them, but like that's really, really, really uncommon. But the bulk of these stones, 80% of the smaller ones are just going to go away on their own. If you are passing a stone, you have a blockage, you've got the flank pain, the blood in the urine, the nausea, like the whole thing, and the stone is small, what we'll do generally as first line as urologist is do a course of what we call MET, which is medical expulsive therapy, which is where we give you medications to help to expel or push the stone out of you. And so what we do is we give you Flomax, which we know causes dilation of the ureters or the drainage system that help increase passage rates. We give you stuff for pain. We give you stuff for nausea. And we say, like, hit it, like drink as much water as you can. And like, let's see how it goes. If you can pass it, great. If you can't, then you're going to be lined up for some kind of a procedure or surgery. This slide, it says uric acid stones can sometimes be dissolved with medications. I'd say that's misleading. If you're in a situation where you have uric acid stones and you have an obstruction, there's no medication that we can take that's going to dissolve stones in the acute setting. I have people come in and they say, well, I had a stone and then I took a shot of apple cider vinegar and now my stone's gone. I feel great. And I'm like, well, that's probably just like, I don't know. Like, if you want to do that and that makes you feel good, then like do it. But like there's no data to support that. So if there are large uric acid stones that are very, very soft in composition up in the kidney, sometimes if we change the pH, the acid-base balance of the urine long enough, then we can like dissolve and erode away those stones over a long period of time. As far as procedural intervention, ureteroscopy is super common. This is where we take a really tiny, flexible scope. We've got this really narrow, like a telescope, and we go kind of what we call it in a retrograde manner. We go backwards up into the urinary tract. So we go in through your urethra into the bladder and then backwards up into the drainage system. And then we find stones and we break them up and we take them out. So there's a couple of different mechanisms for this where you can fragment the stones and then people can pass that dust. And so that's a procedure we call like dusting of stones, where you essentially turn like big rocks into little rocks. Like you make these stones into like sub-millimeter pieces, and then all of that sand after the procedure just kind of like filters out of you. Or you can fragment these stones into smaller pieces. And we've got these little tiny baskets where you grab the stones and take them out. And then stents. I'm sure right now, like looking at the counter of people watching this, there's 314 people watching this. I'm sure like a lot of you have had stents. All of you hate them. I've never met one person that likes a stent, right? It's the bane of our existence as urologists, and you guys hate them as stone formers. But sometimes you just like need it, and that's just, we leave them before these procedures or after these procedures for a certain period of time. That's just part of it, unfortunately. Another common procedure is shockwave lithotripsy. So shockwave, this is like the original like minimally invasive stone procedure. So essentially, if we can find or isolate a stone in the kidney with X-ray or ultrasound, we can use this machine under sedation where we focus sound waves directly onto the stone to fragment the stone. It turns it into small pieces that you're going to pass. This is easy for patients. The complication rates are low. It's really well tolerated. So it's very positive for patients because it's not a lot of BS with it. You just like do the thing, you go home, it usually works. But the downside is that it's not real specific. It's not real focused. And so, you know, if you pick the wrong size stone, the wrong composition of stone, the stone's too dense, it's in the wrong part of the kidney, and you do a shockwave, then you know your results can be pretty dismal. So with shockwave, while it's easy on patients, you know, for stone clearance, it may not be the best thing based on stone composition. So it takes like kind of a careful review of patients, you know, background, what their stone's like, et cetera, to see like, is this, you know, going to be a practical application for the patient. So it's not one size fits all for sure. Percutaneous nephrolithotomy, this is like my baby. This is like what I do every day. So what we do for large stones is essentially shockwave for large stones is not going to break them up. They're not going to pass. Ureteroscopy, going up and like lasering little fragments off of it, would take, you know, 4, 5, 6, 7 different procedures, because the stone is just sometimes these stones are just so big, like literally like stones like the size of your hand. And so the most, you know, efficient way of getting those out of there sometimes is to make an incision in the flank or on the side, and then I've got a camera and some special instrumentation, drive that into the kidney, and then break up these stones. And I've got instruments that flush and pull all of that debris and all that stone out of there, so you don't have to pass it. And, you know, you can do stones that are, you know, the size of a golf ball, you know, 4, 5, 6, 7 centimeters, and you can get those done in, you know, an hour, 2 hours, and you can, you know, people kind of get on with their lives. This procedure used to be a real bear. I mean, it used to be not great. I mean, you know, even 10 years ago, 15 years ago, we would have these procedures at a high transfusion rate. I mean, by transfusion, I mean like getting blood transfusion, like getting blood. A couple of days in the hospital, you got a tube that's hanging out of your back called a nephrostomy tube. And it was just rough, just really rough. These days, and what we've done and what I've done is we've really miniaturized these approaches. So, you know, we used to put like thumb-sized holes in people's kidneys, and it was painful and terrible. And we've like miniaturized all that instrumentation. So, you know, stones that, you know, used to take, you know, 6 hours and 4 days in the hospital now take 45 minutes, and you go home, you know, within an hour after surgery. And so, but this is specialized territory where it's really just people with really large stones. I think we have a video on this if we want to play that. A little walkthrough.
A percutaneous nephrolithotomy is a surgical procedure. The surgeon makes a small incision, about the size of a dime, in your back and inserts a tube directly into your kidney. This allows us to break up and remove the stones. This procedure requires an overnight observation, and most patients will go home the next day. For this procedure, you will have general anesthesia, which means you will be asleep during the surgery. If you are on blood thinners, you must be able to stop taking them before this procedure. This procedure usually requires a stent. A stent is a soft, hollow tube about 10 to 12 inches long and made of a flexible plastic material. The stent is placed in the ureter to hold it open. The stent is usually removed within 1 week after the nephrolithotomy during a brief in-office procedure. For many patients, a stent can cause irritation of the bladder and ureter, which can cause these symptoms: cramping, discomfort and back pain when you urinate, blood in the urine, frequent urination, urinary urgency, and bladder pain. These symptoms can be managed with medication. The benefit of percutaneous nephrolithotomy is it has the highest success rate for kidney stone removal and can clear most kidney stones with one procedure. These are the risks of percutaneous nephrolithotomy. There are higher risks with a percutaneous nephrolithotomy than with any other procedures. There is a 1 in 100 or 1% risk of serious bleeding, for which you would need a blood transfusion. There is a 1 in 100 or 1% risk of fluid buildup around the lungs. If that happens, we would need to insert a needle or tube to drain the fluid. And there is a small risk of sepsis, which is a serious infection. You can usually return to your normal
that's a little bit of a like a basic overview of of PCNL or percutaneous nephrolithotomy. Just like a nice cartoon to kind of show you like what we're talking about, what those procedures are about. Moving on to kind of this is the latest thing. So this is the newest procedure that's kind of coming out across the area. There's a newer instrument called a CVAC, which some of you may have heard of or not. It's made by this company called Calixo, and so the whole process with CVAC is essentially it's really similar to the technology we were talking about previous of running a camera up into the kidney and lasering the stones into small pieces. But CVAC, what essentially we can do is we have a specialized scope that's got like a suction port on it, which we'll show you, where we can, whenever we break up the stones, we can clear large amounts of stone debris out of the kidney with this suction port through the specialized scope. So you can clear huge amounts of stone in a relatively like a time efficient manner where you may not need the percutaneous nephrolithotomy, the incision that go through the back. And this is kind of an overview of what the generator and the scope looks like, where you run the scope up there, you break up the stone, flush all the pieces out, suck them out, boom, you're out of there. This, I will say, this isn't like prime time yet. It's not like widely available. There are insurances that do not cover this. You have to have specific insurances, and it's not available at all hospitals. So like, I know that there's certain Corewell facilities that have it. There's certain Beaumont facilities that have it, but it's not kind of widely available. But that's all going to change within the next 6 months. I mean, this is just like a hugely positive, like really, really excellent therapy option for stones that's going to be widely accepted across all insurances and all hospitals, like within probably the year, I would bet. So this is the new latest and greatest that's coming your way. This slide's like a bit technical with like the measurements and all this stuff, but essentially this scope here, you've got this, you run it up there, it's got the suction port, break up the stone with the laser, flush all the pieces out, and you're good. I think this is a little bit of a better picture. So you can see that this is kind of a blow up of it, continuous flow. So you got this irrigation that it's designed to create like this like swirling vacuum essentially that's just pulling stone out of the kidney as you're lasering it with your laser fiber. Super effective. Does a great job. I think there's a video if we want to play that as well. Pretty cool. Yeah, so that's a pretty dramatic video, but you guys get the idea. So, like I said, with CVAC specifically, that's not widely available yet. There's a couple of places across Southeast Michigan that have it, but like I said, within 6 months, that's all going to change. So, just that's kind of the end of my slides. But just from like a general like overview, the biggest thing is with stones is like testing to figure out like what the hell's going on. I mean, like stones form over wide varieties of conditions. A lot of people make stones, and the majority of these conditions are pretty fixable. I mean, I see people on almost a daily basis where they've had stones for whatever 15, 20 years, and they're like, yeah, every 3 months I pass a stone, and I'm like, well, did you ever like doing testing on that? And they're like, no. I'm like, well, why not? And then we run some really basic urine testing, and then like, boom, we have an answer. And then with some like little medication changes or some, lifestyle changes, that we can kind of like change people's lives and turn these things around. So the biggest thing I would say is like get testing. It's cheap, it's easy, it's super effective, and we can kind of figure out what's going on. And there's some conditions where like I can have an 80 to 90% reduction in stone formation by just like taking a supplement. Like it can just like go away. But if you don't get tested, then I don't know what to do for you. The other big thing is like younger people. So like anybody under 40 that has a stone got to get tested, because there's all kinds of these weird metabolic conditions that can pop up in younger folks. So, anybody, especially teenagers, like you guys got to get in and get tested. If you've got a family history of stones and then your kids start having stones, like these people have to be seen, because, a lot of these things can be preventable. So that's where that would be my like thrust bullet point to all of you guys, is just get testing, and then we can figure it out. There's a couple of questions here in the chat that we can go through. And then if anybody has questions while we're here, you can just like type them away in your little chat box there. The first one, are there medications that can dissolve stones while in the kidney? The answer is that's Bill asking that one. And the answer is maybe. So there are certain stone conditions that can be treated what we call dissolution therapy, and that's largely just like altering the acid base balance of your urine. But I gotta know what kind of stone you got. I gotta know what your other medical conditions are, and I gotta know what your pH balance of your urine is. So the answer is maybe. Other question: why is there a higher incidence of stones across Macomb? And the answer to that is we don't really know. Like there are people that, it's not like everybody's on well water, like we don't really know. We think that in large part it's clustered in kind of like these areas where people are generally kind of like, I don't want to say poor health because that sounds terrible, but like people have like a little more sedentary lifestyle, a little more higher incidence of diabetes, a little more higher incidence of obesity, and that may be it. But in my opinion, I think that there's something else going on. I think that there's something that's environmental, but I'm not smart enough to figure that out. What else? Oh, does Flomax help to prevent stones? I get asked this a lot. So no, the answer is no. So Flomax only helps with stone passage. If you're trying to pass a stone and the stone is in probably like the distal or the lower like third of the ureter, then Flomax will cause dilation to help pass it, but it doesn't prevent stones. Horseshoe kidneys, that's pretty specific. So Arthur's asking a question about horseshoe kidneys. So kidneys are weird. So there's a really high incidence of like anatomical abnormalities with kidneys. You can have like what's called a horseshoe kidney, where you just have like one kidney in your belly. The kidney can be kind of mal-rotated. Any of those conditions where the kidney has an abnormal anatomy, yes, will increase stones. What else? Do any of the moderators, are you guys seeing any like commonalities and questions that you guys want me to address? Because there's a bunch that are coming in now. Explain a sponge kidney. Ooh, that's a good one. Parathyroid. Yeah, I like these. These are good questions, guys. All right, here's one. Parathyroid. So, um, this is pretty specific. So, calcium balance in your body doesn't have to be just like you eat a bunch of calcium, then you have stones. You can have conditions in the body where there's a gland called your parathyroid gland, which is actually in your neck, that kind of goes on the fritz. You can have these like benign adenomas where that gland it does too much. It becomes overactive. And as a result, that will increase the amount of calcium that's in your blood. And then as another result, it will increase the amount of calcium that's in your urine. So there, there are people that I meet and diagnose them where, I'm like, you've been forming stones, whatever. We find out the reason. And the reason is actually they need to go like see an endocrine surgeon to have surgery on their neck, which is a long way away from their bladder. But, but those things can all be related. And we can figure that out. I mean, the testing to figure out if you have a parathyroid problem that's resulting in you forming stones is really, really basic. Like that's really straightforward. Sponge kidney. That's a specific thing. That's kind of like an anatomical problem where the inside lining of the kidney. You can have this condition called a medullary sponge kidney where it's kind of like, instead of like being smooth, that it's like pocketed and looks like almost like the surface of a sponge. And what happens with that is it's just more of a porous environment for sediment and things to stick. So it causes all kinds of like stone accumulation. What else do we got? Drinking lemon water. Drinking lemon water will not dissolve stones. It'll help with citrate, which is stone prevention, but it won't. It won't dissolve any stones you have. Man, there's a lot. Cystine stones, cysts outside the kidney. CVAC and stent. Yeah, you're probably going to need a stent. So one of the problems with that CVAC procedure is that the majority of the time that people need to be what we call pre-stented. So if we're going to do this procedure, we put in a stent beforehand. That stent stays in for 2-3 weeks, and then we schedule you for your CVAC procedure because the stent will cause dilation of the collecting system, dilation of the ureter. So it's easier to get that scope up there atraumatically. So the majority of the time, yes, you will need a stent either before or after, usually before your CVAC procedure. As far as breaking up the stone, using CVAC for stones in the ureter, not great because in the video, like you can see there's like this like swirling mechanism of like all the irrigation going in like a distended area. And if the stone's in the ureter, the suction from the scope is not going to be able to, it's just, the scope's just not going to work great. It needs to be like up in the kidney, but that's a good question too. Can stones be a one-time event? Yeah, they can. So I've got lots of people that I see that have like one-off events where usually it's vitamin C, where they're like, this was huge during COVID actually, where there was a huge incidence of like, or a huge population of people like were like taking giant doses of vitamin C during the initial like COVID outbreaks because I thought it was going to be good for the immune system. Whatever, was like this big rash of stones, and it was just because like you're just taking like just a wild amount of vitamin C, and it'd be like, well, stop that, and then you get their urine testing afterwards, and their oxalate levels are like back to normal, and they're never going to form a stone again. So it can be a one-off event. And then statins influencing stone formation? No, not really. I think we've answered most of these. There's a lot though. Those are the highlights. Does anybody have anything else they would like to ask in the chat? I'll try to answer it. We're going to stick around. I can stick around here for another couple of minutes. Thyroid conditions affect stones formation. Yeah, that's kind of what we just talked about with parathyroid. Parathyroid, thyroid conditions, yeah, can cause stones. This is great. You guys are asking good questions. Smart people questions. Oh, here's one that I missed about oxalates in fresh berries. Particular berries that's worse for stones than others. This person said that they enjoy blueberries, blackberries, and raspberries. You're hosed, man. That sucks. Your blueberries, I believe that blueberries are the most oxalate dense of those three, but all of those are going to be oxalate, high in oxalate. Again, oxalate foods typically are the ones that are good for you. Should you get tested if you've never passed a kidney stone and you're in your early 60s? Yeah. I mean, to do basic metabolic evaluations, that's really straightforward and easy. We could probably get some answers for you. What else? Does lithotripsy scar damage the kidney? Yeah. So you got to be careful. So there's pretty like well documented research about. You're using the word lithotripsy, so I'm assuming you're using, by saying lithotripsy, that you're talking about shockwave lithotripsy. And so yeah, so there's pretty good data on how often and who can get recurrent shockwave lithotripsy. We know that people with high blood pressure who are elderly and obese, you can run into problems with that because you can have renal scar and renal bleeding, those types of things. And it's not something where you want to be like stacking up, shockwave procedures where you're doing it like 2 to 3 times probably 3 times a year. I would be really hesitant about that, just because, these things are not without complications. Like you can cause drama in there. So, encouraging stone passage. If you have a stone that's in the kidney, how can you get it out of there? How can you encourage it to move? Yeah, I tell everybody, like, physical activity, right? Move around. There was a study that was published when I was a resident by other residents that I knew, where they took people who had stones and then they took them to Cedar Point, and then they made them ride roller coasters, and then they imaged them like beforehand and after to see if they like passed the stones, and they had a higher incidence of stone passage after riding the roller coasters. So go ride a roller coaster. Topamax. Yeah, Topamax is a problem. Topamax is, for those on the call, so there's a medicine called Topamax that helps with migraines. It has like some anti-seizure activity too. And Topamax is tough. It can cause like acid base imbalance, and it predisposes you to calcium phosphate stones, which it can be a real bear. But typically, if we have people who on Topamax, if you're on Topamax and you make like a uric acid stone, Topamax ain't the problem. If you're on Topamax and you're making phosphate-based stones, then Topamax would be the problem. And usually I just like call your neurologist or whoever and say, like, get them off of Topamax, get them on something else. There's usually an equivalent to the Topamax that won't increase the incidence of stones. So that's a good question. That's really, really, really common. Max daily intake of oxalate in milligrams, recommendation on that. That's variable because it's not all about how much oxalate you take in. It's about how much calcium you're taking in with it. So if you're eating an equal amount of calcium and an equal amount of oxalate, even at very, very high amounts, those two metabolites, those two things are going to stick together in your gut, and you're going to pass it in your bowels. So if your oxalate intake is super high, then sometimes I'll tell people, like, well, if you're going to just sit around and like eat nuts all day, then you need to like be increasing your dietary calcium as well to help bind all that together so that your oxalate balance doesn't get too high. Impact on sexual function with any of these treatments? Nah, nothing. Should you talk to your doctor to see a specialist to be tested? Yeah, there are some primary cares out there that will do like metabolic testing for kidney stones, but it's pretty rare. I lecture kind of all over town to primary care residencies about like encouraging them to do metabolic evaluations for kidney stones, but they're so busy with everything else that a lot of them just are like, nah, I'll just send them to you. And I'm like, well, that's fine too, I can do it. But yeah, if you're having lots of stones, then you should probably see one of us to get your urine tested. So I think that's it. I think we've been through all of it. Anyway, okay. Well, I think those are a lot of great questions. Those are fabulous. So I hope you guys got something out of it. You know, I think you know, just the take home points would be, if you had a problem, get your pee tested, right? Do your 48-hour urine collection. Have one of us look at it. We can figure it out for you. And then, you know, again, the younger people, we got to get those people in, because prevention is key. And then, you know, you guys drink your water, you know, 2-3 liters of water a day. If you do that, that's half the battle. So anyway, I hope you guys have a good night. I'm going to take off. And if you need anything, reach out to the office. I think there's some phone numbers here that they'll lead straight to my clinics if you need anything from me. So have a good day, guys. Okay. Thanks for everything. Bye-bye.